Hello friends, I am Dr. Deepak Garg. I am Orthopaedic Surgeon and today we will discuss biomechanics of knee in total knee arthroplasty. So in our day-to-day routine activities, we need a knee range of motion minimum of 0 to 100 degree. So our goal in knee replacement surgery is to achieve minimum of this range of motion. Now briefly look at the cuts that we take during the surgery in tibia. In AP axis in tibia, we take a cut, proximal tibial cut perpendicular to the mechanical axis. For the sagittal plane, we take a varying degree of posterior slope. And for the rotational alignment of the tibia, I usually take a static alignment and center of the tibial tray at medial 1/3 and lateral 2/3 of tibial tuberosity. Similarly, in the femur, in anteroposterior axis, that means the distal cut, we take a 5 to 7 degree of valgus to the anatomical axis. That makes the cut perpendicular to the mechanical axis. And for the rotational alignment, there are three methods that we can use. We can take a cut parallel to the epicondylar axis, perpendicular to the AP axis, or 3-degree external rotation to the posterior condylar axis. So this is called posterior referencing. I usually take a 3-degree external rotation to posterior condylar axis. So let's look at the rationale for all these cuts. Now let's talk about the tibia. So now the angle between the vertical axis and the mechanical axis of tibia is 3 degree. So if we look at the medial proximal tibial angle, the medial proximal tibial angle is 87 degrees, but we are cutting it at a 90 degree. So this angle is 87 degree. When we take a cut perpendicular to the mechanical axis, that means that the 90 degree. So we are cutting more on the lateral side. So by taking this angle perpendicular to the mechanical axis from the normal anatomy of tibia, we are cutting 3 degree more on the lateral side of the tibia. So similarly, if we look at the femur, so in the femur, the angle between the anatomical axis and mechanical axis is 6 plus minus 2 degrees. And the angle between the vertical axis and mechanical axis is 3 degree valgus. So again, if we look at the lateral distal femoral angle, it is 87 degree. Now we are cutting perpendicular to the mechanical axis. So that means we will be cutting more on the medial side. So cutting to the mechanical axis, we will be cutting more on the medial side. So in tibia, we have taken a cut 3 degree more on the lateral side, and in femur we have taken a cut 3 degree more on the medial side. So this balances our extension gap. That's why after taking these cuts, we first have to see whether our extension gaps are rectangular or not. So now let's look at the rotational alignment. Now what is the problem with the rotational alignment? When we are cutting the tibia, we are taking a tibial cut. So we are cutting the tibia at a slope, but we are not cutting the tibia according to the normal anatomy of the tibia. We have cut more on the lateral side. We have cut more 3 degree more on the lateral side. So when we are cutting in a slope, that means we are cutting 3 degree more bone on the posterolateral side. So this will relaxes or increases the gap on the posterior lateral side, and this will lead to the gap tightening on the medial side. Now this is difficult to balance. So to balance this gap, let's understand the rotation of the femur. So now this is the femur, this is the external rotation of the femur, and this is the internal rotation of the femur. So let's see. Now we want to cut more on the medial side. So we want to cut more on the medial side. So that we can have the more relaxation on the medial side of the tissues, and we can have the balanced flexion gap. So what we have to do, we have to cut the femur in external rotation. Now we have cut tibia 3 degrees more on the lateral side. Now we have to cut femur 3 degree more. So that what should we do to achieve this? We will have to take 3 degree of external rotation. That's why we take a rotation of the femoral component is we alter it from the normal anatomical position and we take 3 degree externally to create a symmetric flexion gap. So that's why we take 3 degree more, 3 degree of external rotation. So that's create a rectangular flexion gap. So we have already seen that there are 3 methods. We can take a posterior referencing and we can take 3 degree of external rotation to the posterior condylar axis. So now the alignment of the tibial component. So this is the last step that we usually do in our total knee replacement surgeries. So static method, medial 1/3 and lateral 2/3 of the tibial tubercle, we take a reference and then we take a tibial alignment, rotational alignment, and we create a rectangular extension gap and a rectangular flexion gap. Now choosing the cruciate retaining versus posterior stabilized component. So this is a cruciate retaining and this is a posterior stabilized component. So now what is the difference that we take in our knee replacement surgeries when we choose cruciate retaining versus posterior stabilized? When we do a cruciate retaining, we usually aim for a slope of around 5 to 7 degree. When we use a posterior stabilized, we take a small slope which is recommended is around 0 to 3 degrees. Now choosing a polyethylene, we should choose a minimum thickness of 8 mm. Thinner polyethylene will have a higher accelerated wear rates. So these days we are using a highly cross-linked polyethylene, and for the component fixation we use a PMMA bone cement. So this was about the biomechanics of knee in total knee arthroplasty, stepwise, understanding the stepwise approach. So for more such videos, please like, share and subscribe to our channel. Thank you.